All right, we still got a few people joining, but I'll go ahead and make the introduction and then we'll start our presentation. Welcome everyone to today's ACLP Virtual Journal Club session. As a reminder, we are working our way through the ABPN's article-based pathway for maintenance of certification for C-L Psychiatry. If you are interested in presenting at a future journal club, please let us know and we can discuss it. Now for today's journal club session. I'm very pleased to introduce Dr. Brian Bronson. Dr. Bronson is a clinical professor of psychiatry at Stony Brook University, where he serves as director of Consult-Liaison Psychiatry, Division and Fellowship Program, as well as the Vice Chair for Hospital Clinical Affairs. Dr. Bronson has a long-standing interest in leading program innovation and scholarship related to the delivery of health services to manage psychiatric and substance use disorders in non-psychiatric medical settings. Dr. Bronson serves on the board of ACLP and chairs the ACLP Consultation-Liaison Psychiatry Division Directors Forum. Today, Dr. Bronson will be discussing a 2019 article entitled "The Impact of Integrated Psychiatric Care on Hospital Medicine Length of Stay, a Pre-Post Intervention Design with a Simultaneous Usual Care Comparison." In terms of logistics, Dr. Bronson will speak for about 20 minutes, and then we should have about 8 minutes for discussion. If you have any questions for Dr. Bronson, please use the Q&A feature, and I will try to get through as many questions as I can at the end of the presentation. All right, take it away, Dr. Bronson.
You're on mute, Dr. Bronson.
Okay, thank you so much, Christine. Can you see my screen now?
Yes, looks good.
Okay, so thank you to all of you who have joined today. I'm going to be, well, talk about the research and the paper. I'm assuming a lot of the participants today are also clinicians and are interested in program development. So I'm going to try and balance talking about this from how I started off as a quality improvement initiative slightly over 10 years ago, actually, and then evolved into research. And we'll have some discussion about sort of how bridging quality improvement and health services research. Okay, and I'll just say this is a paper I authored with Al Alam, who's currently at the VA in San Diego and USC, and Joseph Schwartz, who's at Stony Brook, who's a very senior level researcher and statistician who I'll talk about. So I'm going to go back to when I first joined the Stony Brook University in 2013. And at that time, they were going through a transformation of a new university president, and all the chairs had changed over. And I was recruited at that time, and with the explicit goal, I was told to grow the C-L service. And it's probably not that common that you are hired with that expectation in mind. I think that was a good thing for me because I liked doing that anyway. And it just meant I had a little bit of political support starting off, which does make a difference if you want to, grow programs. So for those of you who are not familiar with Stony Brook University, we're part of the State University of New York system. We're one of the flagship university hospitals of New York. And the medical center serves the Suffolk County, which is approximately 1.5 million residents. And we're the only university tertiary care academic medical center, level 1 trauma center for Suffolk County, which means not only do we have some people coming from locally, but the vast majority of patients are coming from all over the county, many of them being transported by helicopter and other means, and often transported from other community hospitals in the region for more complex care. So I had started this job in May of 2013, and that fall I went to the ACLP meeting, which was at that point was still being called the Academy of Psychosomatic Medicine. And I heard this really interesting paper that at the time was sort of relatively new. It was presented by Paul Dizon, who many of you know. And Paul is at Yale and did this paper with Paula Zimbrian, who many of you know, and then William Sledge was the senior author of the paper. So I read, Paul had presented this this work at the Academy of Psychosomatic Medicine meeting in 2013. And it was, relatively brief session. I was really impressed by the whole concept that they, were trying to sort of redesign C-L services in a way, whereas historically, consultation-liaison psychiatry is often it's often been thought of as sort of generated on demand, right, or reactive in terms of who is seen for consultation and care. The proactive model focused on screening, early identification, sort of being an embedded team on a general medicine floor, having that sort of higher level collaboration with the hospital medicine staff, social workers and nurses. And it was a great concept. Actually, a lot of my work before I came to Stony Brook was in the VA health system and was very involved in sort of regional implementation of primary care mental health integration. So I'd already had a lot of interest in sort of different levels of integrated care. So this made a lot of sense to me. But I think what was really interesting is they talked about length of stay and a little bit about health economics and how they had, based on their calculations, generated a positive return on investment. So I had always had an interest in sort of health services and thinking about cost. And this was really exciting for me. So I came back to Stony Brook after the meeting. And right away, I saw this as a way to possibly meet the needs of our own health system and also grow services. There was a lot of discussion at the time at Stony Brook about length of stay, particularly in hospital medicine, and that it was too long. And it was really an area that was a focus for the finance and sort of executive leaders of the health system. So immediately I started talking to a few colleagues and at sort of more senior levels in the institution and started requesting data just to ask basic questions like, well, what is the prevalence, right, of active psychiatric or substance use disorders on our hospital medicine units? And we got some data back that showed it was approximately 48% at that time of patients discharged from our hospital medicine units based on fee coding data collected after discharge by our fee coders had that prevalence. So that was the first thing I think got the attention of our executive leadership and finance leadership of the hospital. And then we looked at the second graph on the right, the length of stay. They were equally impressed by this data that if they separated those with a psychiatric or addictive diagnosis and those without, the length of stay was more than 2 days different. And that was very impressive. So we started talking about a possible proposal and what if we got the length of stay down by half a day or 0.2 days, and what would it take to sort of cover the cost of the program and so forth. So I also started talking with the chair who had recruited me at the time, and the chair's advice at that point, which I think was good advice, was why don't you go on with a big proposal and something very comprehensive, and we'll see where sort of we land. But so I looked at all the lengths of stay and sort of prevalence of psychiatric conditions, as well as where we were being consulted for. And the areas that were most, I'd say, relevant to this potential initiative were 4 of our hospital medicine units, our trauma ICU, which is very busy and which we consult a lot. And then we have an acute cardiac area, which was also a high area. And I sort of envisioned that we would have, based on the sort of roughly the Yale staffing model, and we would cover basically we would cover 6 units. For those units, I requested 3 nurse practitioners and 3 psychiatrists, was actually maybe even more staffing as necessary in retrospect. So we went in with this fairly large proposal, and they came back and they were very interesting idea. They said, well, why don't we approve a pilot, and we'll give you like a line for 1 new psychiatrist and 1 psychiatric NP to cover 2 hospital medicine units. And then if you're successful in doing what you're saying, and you could actually lower the length of stay, and it covers the cost more or less, then we'll fund the rest of your proposal. So we agreed that we would study length of stay in the pilot unit, and we would actually use the other sort of three medicine units as active comparison units, and we would look at the return on investment. And the main source of income from this initiative would be by refilling beds. At the time, only about half of our patients' insurance was paying through diagnostic-related groups, meaning fixed payments based on the diagnosis. Since then, almost all of our discharges are being paid paid based on DRG-related payment systems, which means fixed payments based on a diagnosis or complexity. At the time, it was about half. So we calculated that basically those were based on those numbers and refilling beds if we got the length of stay down, because our demand is continuous, our ER is full, and our hospital is relatively full. So we refill the beds as beds opened up, and that would generate additional revenue, which would hopefully cover the cost of the physicians. We had one psychiatrist, Dr. Alam, who actually was very interested in this program and was already on staff. So he embraced this and agreed to take this on to actually implement this. We did not have a nurse practitioner, so we decided we would just start with Dr. Alam as the the primary lead on this program. And the basic model, sort of in simple terms, was Dr. Alam would be co-located on one patient medicine unit, not two, because there wasn't a nurse practitioner to extend the services. He'd focus on early case finding through screening and early intervention, daily rounds with the medicine team and social worker, and they would proactively address psychiatric barriers to discharge. So here's Dr. Alam, is the one second from the left, and Amy Rahim is on the left of him, and she went and did a C-L fellowship at NYU, was working in the field. Alexander Zaverinsky is on the right. He also did a fellowship with us. Charles Mormando's at Penn State now, works with Elizabeth Kunkel doing ECT. So this was the sort of moment where we were just starting the program. And but actually, I would say, take a step back. Before we started, Dr. Alam and I decided we really wanted to go up to Yale and see their program. So I reached out to Ben Lee, who at that point was at Yale and was the sort of lead for the psychosomatic medicine services, and was very gracious and invited us to spend a day with him and Dr. Dazan and William Sledge to really learn from them. And it was an incredibly helpful visit. One of the most useful pieces of advice we received was from Dr. Sledge, who said you really have to go in there with a focus on length of stay, and you can't just provide sort of consultative care, but you really have to be very explicit about it, and not necessarily get caught up in patients who may benefit from support, but supportive therapy, for example, but may not yield as much. You really want to focus on the patients with the highest likelihood of making intervention and sort of improving the outcomes and that length of stay metric. So after a year of doing this, we collected our data, and the left shows the percentage of patients discharged from the unit with consultation, and it's about double, so about 20% of the patients discharged from the intervention unit. Dr. Alam had, actually at this point it was 14%, later went to 20%. It was about 14% had a consultation, one or more consultative visits, versus 7.5% in the pilot unit. I'm sorry, it was 7.3%. It went up to 14% on the pilot unit, and then the usual care units, it was stable. So it had been 6.8%, and then in the post-intervention period, it went up to 7.66%. Something else I'll just mention, which was interesting, and this isn't clear from the paper if you read it, because after we had feedback from the editors, we had to modify some things to meet their satisfaction. But our finance people were very interested in not the absolute length of stay, but actually what was the excessive length of stay as compared to Vizient. Many of you know what Vizient is, and they provide a sort of they try and provide a risk stratification to predict what the length of stay should be based on their own formulas. And so our finance people were interested in how much longer was our length of stay for a given patient, and on average on those units compared to what Vizient thought it should be based on their formulas. So they wanted to look at the change pre-post on the pilot units, right, and the change pre-post on the usual care units as compared to what it should have been per Vizient. I'll just say now, when we submitted the manuscript, they came back, and one of the editors was very firm about not wanting to use Vizient data, felt like it was proprietary and wasn't sort of wasn't really a standard that had been proven and had evidence to support it. So we had to go back and although we had analyzed the data both with and without Vizient, we did a few different ways. I had to modify the paper in a significant way to satisfy that reviewer. And then the financial analysis, in the end, when we looked at the change in length of stay in the usual care units, not unexpectedly, there was really no revenue based on change, whereas the pilot unit, based on the on that change, as compared to the Vizient length of stay, we had estimated generated approximately $400,000. So when we took out the cost of the psychiatrist's salary and the benefits and other things, in the end, it was a positive return investment. So more than 100% of the costs were covered. So our finance people and our CEO and CFO, they were very happy with this. And then when we just did some informal surveying of the hospitalists in terms of what was their feedback, and this wasn't published or anything we disseminated, but there were a lot of comments, and they made comments such as there was increased availability of psychiatric intervention, there was improved timeliness with respect to discharge, and that the timeliness was also better with respect to documenting what they required to make that discharge. So I'm going to now shift and try and speed up a little bit to make sure we have time for questions to the publication, because it's one thing to have a quality improvement initiative, but to actually be publishable and sort of format it and reorganize it and analyze it in a way that's publishable is a higher standard in terms of what kind of methodology and rigor would be expected for a peer-reviewed journal typically. So I was very fortunate that Joe Schwartz, who is a very senior level statistician researcher that works here and also at Columbia, was agreeable to working with me on the paper. It was very helpful. We started meeting, and along with Dr. Long, and we started to find what a statistical analysis would include, that we would look at patient characteristics, which is an important piece of analyzing outcomes, and look at things like the age, the gender, the where they would be discharged to, whether to home or another facility, looking at insurance, whether they had Medicaid, in terms of an indirect marker maybe of their economic status. And then we would look at the change in length of stay, both as far as hospital days as well as excess days, the Vizient excess days that our finance people were interested in. And then given the data that Dr. Dazan's group had published, that this kind of initiative seemed more impactful on if you remove long stay patients, right? So just including patients with a length of stay less than 30 days, we were going to do a sensitivity analysis just limited to that slightly smaller population. So I'm going to skip this slide for time, but I will come back to the concepts. And this is, you can see the paper. Again, this is a typical graphic, and ultimately it shows the last two rows, it's patients with a psych consult, and with a psych consult length of stay less than 30 days. This is basically the groups of patients that we had examined. So we looked at length of stay on the usual care units, pre-implementation and post-implementation, and then the length of stay on the patients consulted on the intervention unit during 2014, which was the pre-intervention time, and during the intervention, which was 2015. Okay, and again, I'm not going to spend a lot of time looking at the details. This is all in the paper, except to say there weren't really what we felt any significant differences in any of the major demographic or other features which we felt could impact length of stay across the usual care or intervention units, either during the pre or the post-intervention period. And just sort of in brief, so what was the result of our statistical analysis? So the length of stay decreased in the intervention unit in the pre-post, which is what the Dr. Dazan's group did a pre-post-pre analysis. So that was statistically significant. The length of stay was also shorter on the intervention unit, both in the pre-implementation period as well as the post-implementation period. But then the most rigorous hypothesis that the difference of the differences would be significant was not significant. It was almost significant at 0.07, but did not reach that level of 0.05. So the question here was, if we compare the change in length of stay, right, pre-post on the intervention units to the change pre versus post on the usual care units, right, was that a statistically significant change? And it was not, although it was close, as I mentioned. And then we did the same. This is just the actual data, which I won't go through with the actual length of stay differences, but it was essentially for those areas that have a p-value less than 0.05, the length of stay adjusted was about 1.79 days on average. And then when we use the difference of the difference, right, the bottom line, that most rigorous hypothesis, it was 1.49 days on average. But that was a 0.17 p-value. Then we redid the data excluding patients with length of stay more than 30 days, it was 1.13 days. And it was a sort of trending towards significance with a 0.07 p-value. So I think I'm up to my last two slides. So the first question is, in practice, how do we actually get the length of stay down? So as I mentioned, we focused on screening and early intervention. There was a daily rounds, which doesn't typically occur on a general sort of C-L service, where you might see a patient every day. Potentially you might not, but you're not really in a meeting every day or speaking every day to the social worker and the hospitalists about the discharge plan from early on. There was definitely a unit culture shift, which I'll talk about. And but essentially the goal was really explicitly to reduce length of stay, and I think that was a goal that the social workers and hospitalists understood. I think Dr. Alam was particularly effective. He had worked some years in a leadership role in psychiatry emergency, so was very comfortable with sort of rapid assessment discharge. He also was himself was trained in internal medicine and boarded, and worked as a hospitalist doing ER moonlighting. So was again comfortable with sort of making decisions about safety and discharge. So he was particularly good for this program. He was comfortable sort of pushing the discharge, and also the hospitalist respected his judgment, was very helpful. And he wanted to succeed. It was very important to him that we succeed in this initiative. So I think that was very useful. Of course, we had a high psychiatrist to patient ratio with one psychiatrist to 30 beds is much higher than would occur in a typical C-L service. We have, at the time we had 500 beds, non-psychiatric beds, and 2.5 psychiatrists. So the ratio is very different. That higher ratio would allow him to see patients daily or even several times daily if needed. This is like a timeline of what happened after the pilot in our system of care, and it's really interesting, and it does inform the lessons learned that I'll talk about after this. So we did have 4 lines approved for this in 2015. It took us a little while to recruit staff, which is always a challenge, although we did continue to operate this with Dr. Alam and our first nurse practitioner 2 units, and we expanded to 4 units. But what I would say is there was some drift, program drift, which is common if you have a sort of a clinical trial or a QI project. After you do that, the C-L psychiatrists who do doing general C-L sort of rotate on and off this initiative just to kind of keep everyone engaged and not sort of lose, I think, the freshness about trying different things. The embedded staff became increasingly dependent, which was good and also bad in some ways in terms of them calling more what we felt were lower yield consults that weren't always going to have as much impact. And the focus on length of stay really was almost forgotten about over time. And I think that although we didn't measure it either, which was also probably part of the reason we weren't focusing on it, I think these factors, although the program was very effective and it was very popular and there was great appreciation for the program, I can say that I had data to say that we sustained a length of stay reduction. For different reasons, both nurse practitioners that we had resigned within a year around 2019. And then early 2020, of course, COVID-19 pandemic launched, and this created chaos, as I'm sure it did for most of your systems, where units that had been hospital medicine units were now being reassigned as either COVID units. The hospitals were covering different parts of the hospital. The whole sort of organization of our units and our patients and our staff was thrown off. So it became really impossible to have a proactive C-L service at any level of collaboration or integration at that point. So we paused it. We did build an electronic tool to identify patients for consultation rather than doing it sort of manually with a chart review, and that was very helpful. One of the MPs came back for a little over a year around 2021, and we piloted that with a lot of success. But the program is currently on hold. We had a sort of had to rebuild some of our staffing after the pandemic, which we lost, and we're slowly growing it back. So our hope is to reestablish the program, but it did not last beyond, I'd say, the 4 or 5 years we had it. So then the question is, what in my view made this publishable? Well, I think the question was relevant and still relatively novel. There's been a lot of papers on proactive C-L, but at the point there wasn't a lot published still. I think if you think about project design for any research question, we hit a lot of the elements of a clear question, a clear population. The intervention was clear. We could describe it easily, but it could be replicated. We had a live comparison group. The outcomes data were clear and had access to data, which was important. And then we had a very robust analysis with a very sort of sharp statistician. So for me, lessons learned were that institutional alignment and support was very critical for this program. We had clear questions and metrics. I had access to data, which was critical. The implementation team with Dr. Alam in particular was very helpful. And then over time, we did have some drift, and the sustainability was sort of not as strong as I'd hoped, given some loss of staff. and also some, as I mentioned, some drift. So I'm going to stop there. So we have a few minutes of questions, and I really appreciate all of your attention.
Thanks, Brian. I'll go ahead and ask the first question that's in the Q&A box. First, they said, thank you for this wonderful talk and for developing this great program. And I agree. I think this was a wonderful talk and I learned a lot. The question is, I was curious to hear about interventions to specifically target length of stay that can be used regardless of the model of consultation, whether proactive or reactive. And of course, would like to hear about what interventions you use in your program specifically and aspects you pay attention to in the consult itself that pertains to length of stay.
That's a good question. I mean, I'll just start off by saying that the only area, well, there's two things that have been published, and I always try and focus on evidence when there is evidence. And the areas of research that I've seen in this are so certainly the proactive model, and you could take elements of the proactive model even if you don't have the full sort of program. And although maybe that's not been, single elements haven't been researched, it's more the cluster, I think, of elements. The things that are relevant and required are the proactive identification of consults. So we have an electronic screening tool. So at Dartmouth, they have a very robust sort of proactive model, but it's really based on identifying people anywhere in their system, whether they're ED or any of their units, and it's not necessarily limited to a hospital medicine unit. So if you had a way of identifying patients through an electronic tool or other process, you could just be more proactive in seeing patients. And what does proactive mean? Well, it means two things. It means the timeliness, so seeing them earlier, and then of course it's that follow-up that's very important. There's other research looking at length of stay as it pertains to the timeliness of consultation. So the earlier you see the patient after admission, right, the more likely you are to impact length of stay. So if you were able to, again, focus on, not putting off the next day, encouraging your hospitalists or other staff to call you right away on admission if there's an issue, or not wait 2 or 3 days. So that could also impact length of stay.
We've got 2 more questions in the box. The first one is pretty brief. Did AMA discharges affect the results?
It's a very interesting question, and I don't have the answer, but I did think about that, and it's a great question. It's something that should definitely be studied.
And was there any data on the patient perception or satisfaction with the model?
So in our particular study, we didn't study patient satisfaction, and I believe that some of the papers have looked at that. Anecdotally, I heard lots of feedback that the patients were very happy because they received a level of attention and support they may otherwise not have received. I think, in a usual reactive sort of on-demand CL service, the tendency might not to provide as much support, as much frequency of sort of that bedside support. We had a nurse practitioner and a psychiatrist for 2 units. That's a very high staffing ratio. So, and the nurse practitioner not only was sort of functioning as a sort of quarterback of the service, but also providing a lot of bedside support. So I think anecdotally, the patients did appreciate that.
Wonderful. And I've got one last question in the box, and I think we have time for that one. Did you find that as the program went on, that patients with psychiatric diagnoses were preferentially sent to the intervention unit, which might have influenced the results?
Yeah, also an excellent question. Definitely something we thought about. I think there was probably some of that happening. Do I think it was the majority of the patients? No, and I'll explain why. Our hospital generally runs at almost 100% of our maximum census, which means they have to fit the patients where they have beds available. So there's not that much control in where they sit them, but to the extent it's feasible, if a patient did come in the emergency room and there was a heavy sort of comorbid behavioral component or psychiatric component, I think there were some cases where I believe they suggested that we send a patient to the integrated unit. So I'm sure that some minority of the cases were sent for that reason.
Wonderful. Well, we're just up on the hour, and I thank you very much for your presentation. Please join us in a couple of months for our next presentation in June, and we'll send out more details through the email.
Thank you so much for this opportunity. I really enjoyed it. And if anyone wants to reach out to me with questions afterwards, I'd be welcome to that. Thank you so much.